After 30 years in medicine, there are 5 medical tests I would refuse after turning 60. And what I'm about to tell you might shock everything you've been told about health screenings. Listen, I need to tell you something that might shock you. After practicing medicine for over 30 years and seeing thousands of patients, I'm about to reveal the 5 medical tests and checkups that I would absolutely refuse to get after turning 60 years old. And no, this isn't about being anti-medical care or reckless with my health. In fact, it's quite the opposite. What I'm about to share with you comes from decades of clinical experience, research, and watching too many patients suffer from unnecessary procedures, anxiety, and treatments that did more harm than good. So if you or someone you love is over 60, I'm asking you to stay with me for the next few minutes because this could fundamentally change how you approach your healthcare and possibly save you from unnecessary medical interventions that could diminish your quality of life. My name is Dr. Michael Thompson, and before we dive in, I want to make something crystal clear. I'm not telling you what to do. I'm not your doctor, and I don't know your individual medical history. What I am doing is sharing my professional perspective based on evidence and experience about tests that are commonly pushed on older adults, but may not be in their best interest. The decision about your healthcare should always be made between you and your physician, who knows your complete medical picture. But I believe you deserve to know what many doctors won't tell you about these common screenings and checkups. Let me start with the first medical checkup I would never get after 60. And this one surprises almost everyone I talk to. Annual prostate cancer screening with PSA testing for men. Now, I can already hear some of you gasping. We've been told for decades that this test saves lives, that every man over 50 should get it, and that skipping it is basically signing your own death certificate. But here's what the research actually shows, and why I would personally refuse this test after 60. The prostate-specific antigen test, or PSA test, measures a protein produced by both normal and malignant cells of the prostate gland. The problem is that this test is incredibly imprecise. It can't distinguish between aggressive cancers that might actually harm you and slow-growing cancers that will never cause any problems in your lifetime. And here's the kicker. Most prostate cancers in men over 60 are the slow-growing type. Studies have shown that many men die with prostate cancer not from it. In fact, autopsy studies have found that up to 70% of men in their 70s have some prostate cancer cells, but the vast majority never knew it and never had any symptoms because these cancers were so slow-growing they never posed a threat. So, what happens when you get a PSA test after 60? Well, if it comes back elevated, you're sent for a biopsy. That biopsy itself carries risks including infection, bleeding, and significant anxiety while you wait for results. Then, if cancer is found, and remember, we're often finding those harmless, slow-growing types, you're faced with treatment options. Surgery or radiation for prostate cancer can lead to incontinence and erectile dysfunction, dramatically impacting your quality of life. Multiple large studies, including one published in the New England Journal of Medicine, have shown that PSA screening does not significantly reduce prostate cancer deaths, especially in men over 60. The United States Preventive Services Task Force actually recommends against routine PSA screening for men over 70 and suggests that men between 55 and 69 should make an individual decision after discussing the limited benefits and substantial harms with their doctor. I've seen too many men in their 60s and 70s go through the emotional roller coaster of an elevated PSA, undergo painful biopsies, and then face terrible side effects from treatments for cancers that likely would never have bothered them. These men went from feeling perfectly healthy to dealing with incontinence pads and sexual dysfunction, all because of a screening test. That's why after 60, I would skip the routine PSA screening unless I had specific symptoms or a very strong family history that warranted closer monitoring. The second medical checkup I would refuse after 60 is routine mammography screening for breast cancer beyond age 75 and for women with significant health conditions even earlier. Now again, this is controversial because we've been told that mammogs save lives and every woman should get them regularly. But let's look at what happens in reality for older women. As women age, particularly after 75, the benefits of mammography screening decrease while the harms increase. Why? First, breast cancer tends to grow more slowly in older women, so even if it's present, it's less likely to be life-threatening within their remaining lifespan, especially if they have other health conditions. Second, mammogs lead to a lot of false positives. That means the test suggests cancer might be present when it actually isn't. These false positives lead to anxiety, additional testing, and sometimes even unnecessary biopsies. Here's something most people don't realize. For every life saved by mammography screening in older women, many more women are harmed by overdiagnosis and overt treatment. Overdiagnosis means finding cancers that would never have caused symptoms or death in a woman's lifetime. But once found, these cancers are typically treated with surgery, radiation, or chemotherapy, all of which have significant side effects and risks, especially for older adults. The American Cancer Society now recommends that women 75 and older should only continue screening if they have a life expectancy of 10 years or more. If a woman has serious health conditions like heart disease, diabetes, or other issues, continuing mammography makes even less sense because she's more likely to die from those conditions than from a slow-growing breast cancer. I understand the fear around cancer, I really do, but I've watched too many women in their late 70s and 80s go through the trauma of biopsies, lumpectomies, and radiation for tiny cancers that were never going to harm them while their quality of life suffered tremendously. One of my patients, a vibrant 80-year-old woman, had a small cancer detected on mammography. She underwent surgery and radiation, developed severe fatigue and pain, and spent her remaining years far more limited than before. All for a cancer that likely would have grown so slowly it would never have caused her any problems. That's the kind of outcome I want to help you avoid. The third checkup I would never get after 60 is routine colonoscopy screening, particularly after age 75, or if I've had several normal colonoscopies already. Now, colorectal cancer screening is important, and I'm not saying to never screen for colon cancer, but the way we approach it after 60 needs to be much more thoughtful and individualized than the one-size-fits-all approach most doctors take. Here's the thing about colonoscopy. It's an invasive procedure that requires sedation, carries risks of bleeding and perforation of the colon, and requires a pretty miserable bowel preparation the day before. For younger people at average risk, the benefits of detecting and removing precancerous polyps generally outweigh these risks. But after 60, especially after 70, the equation changes significantly. If you've had 1 or 2 normal colonoscopies already, your risk of developing colorectal cancer is quite low. Most guidelines now say that if you've had normal colonoscopies, you can stop screening altogether at age 75, or even earlier if you have other serious health conditions. The reason is simple. Colorectal cancer typically develops slowly from polyps, taking 10 to 15 years to progress. So if you get a normal colonoscopy at age 65, you're unlikely to develop cancer before age 75 or 80. And if you have other health conditions that might limit your lifespan, undergoing the risks of colonoscopy doesn't make sense. I've personally seen complications from colonoscopy in older adults, including perforations requiring emergency surgery, severe bleeding, and complications from sedation, including falls and confusion afterward. There are also less invasive screening options now like stool-based tests that can be appropriate for older adults who still need screening but want to avoid the risks of colonoscopy. The key point is this. After 60, particularly after multiple normal colonoscopies, routine colonoscopy screening often provides minimal benefit while exposing you to real risks. Yet, I see doctors routinely scheduling 75 and 80-year-old patients for colonoscopies without having serious conversations about whether the benefits truly outweigh the risks for that individual. That's not patient-centered care, and it's something I would refuse for myself. The fourth medical checkup I would skip after 60 is annual full-body skin examinations by a dermatologist if I have no history of skin cancer and no concerning lesions. This might seem strange because we're constantly told about the dangers of melanoma and skin cancer, but here's what the evidence actually shows about routine total-body skin exams in older adults without risk factors. There is actually no strong evidence that routine full-body skin in people without risk factors reduces melanoma deaths. What it does do is lead to a tremendous amount of biopsies for benign lesions and the detection of many non-melanoma skin cancers that might never have caused problems. As we age, our skin develops all kinds of spots, moles, and lesions. Most are completely harmless, but when a dermatologist examines every inch of your skin, they're likely to find something they want to biopsy just to be safe. This leads to anxiety, procedures, and scarring, often for no benefit. Now, I'm not saying to ignore obvious changes in your skin. If you notice a mole that's changing, bleeding, or looks suspicious, absolutely get it checked out. And if you have a history of skin cancer or significant sun damage, regular monitoring makes sense. But routine annual total body exams in older adults without these risk factors often create more problems than they solve. The biopsies themselves carry risks of infection and scarring, and the psychological stress of waiting for results and dealing with procedures is real. I've had patients in their 70s who started getting annual skin checks and ended up with dozens of biopsies over the years, significant scarring, infections, and constant anxiety, yet never actually had a melanoma or anything life-threatening detected. The harm from all those procedures outweighed any theoretical benefit from screening. That's why I would personally skip routine total body skin exams after 60, unless I had specific risk factors or concerning symptoms. Self-examination and being aware of changes is important, but routine professional screening in low-risk older adults often does more harm than good. The fifth and final medical checkup I would refuse after 60 is bone density screening beyond the initial test or once osteoporosis has been diagnosed and treated. DEXA scans to measure bone density are routinely recommended for women over 65 and men over 70. And yes, that initial scan can provide useful information about bone health and fracture risk. But here's where it goes wrong. Many patients end up getting repeated DEXA scans every year or two, and those repeated scans rarely provide useful information and often lead to anxiety and overly aggressive treatment. Bone density changes very slowly. Unless you've started a medication that significantly affects bone density, there's no reason to repeat the scan more frequently than every few years at most. Yet, I see patients getting annual DEXA scans, watching their numbers fluctuate slightly, which is often just normal variation or measurement error, and then getting anxious or having their medications adjusted based on these minor changes. The focus becomes chasing numbers on a scan rather than focusing on what actually prevents fractures, which is maintaining strength, balance, and avoiding falls. Furthermore, once osteoporosis is diagnosed and treatment is started, whether that's medication, calcium, vitamin D, or weight-bearing exercise, repeatedly checking bone density doesn't change management much. You should continue the treatment regardless of minor fluctuations in the scan. What matters more is whether you're actually having fractures, not what the exact number on your DEXA scan is. I've watched patients become obsessed with their bone density numbers, constantly worried about small changes, taking increasingly aggressive medications with significant side effects, all while not focusing on the things that matter most, like staying active, preventing falls, and maintaining overall health. There are also concerns about overt treatment of osteoporosis based on DEXA scans alone. Many people, especially women, are put on bisphosphonate medications for borderline bone density numbers when their actual fracture risk is quite low. These medications have potential side effects, including jaw problems and atypical fractures with long-term use. So the question becomes, are we treating a number on a scan, or are we actually preventing fractures and improving quality of life? After 60, I would get one baseline DEXA scan to know where I stand, but I wouldn't get caught up in the cycle of repeated scanning and number chasing that so many older adults fall into. So those are the 5 medical checkups I would refuse after 60. Routine PSA testing for prostate cancer, routine mammography after 75 or earlier if health is poor, routine colonoscopy after multiple normal exams or after 75, routine full-body skin exams without risk factors, and excessive bone density screening beyond an initial baseline. Now, I want to emphasize something crucial. I'm not suggesting you avoid all medical care after 60. That would be foolish and dangerous. What I'm advocating for is thoughtful, individualized healthcare that considers your specific situation, your overall health, your life expectancy, and most importantly, your quality of life. The problem with modern medicine is that we've become very focused on screening, early detection, and treating every abnormality we find without always considering whether that approach actually benefits the patient in front of us. This is especially problematic for older adults because the benefits of many screenings decrease with age, while the harms increase. Every test, every procedure, every intervention carries risks. For a younger person, those risks might be worth taking for the potential benefit of adding many years to their life. But for an older person, especially one with other health conditions, the calculation is different. What I want you to take away from this is the importance of having honest conversations with your doctor. When a screening or test is recommended, ask questions. What are we looking for? What will we do differently if we find something? What are the risks of the test itself? What are the risks of potential treatments if something is found? Given my age and overall health, what are the realistic benefits of this test? These are all fair questions, and a good doctor will take the time to discuss them with you rather than just ordering tests automatically because that's what the guideline says. I also want to talk about something that doesn't get discussed enough, and that's the concept of overdiagnosis and overtreatment in medicine. We have this idea that more healthcare is always better, that finding disease early is always good, and that aggressive treatment is always the right choice. But the reality is much more nuanced. Sometimes finding a disease early, especially a slow-growing cancer, leads to treatments that harm quality of life without actually extending life. Sometimes the anxiety and stress of knowing you have a disease, even if it's being monitored, is worse than never knowing. And sometimes the complications of treatment are more harmful than the disease itself would have been. This is particularly true for older adults. The medical system often treats a 75-year-old the same way it treats a 50-year-old, without acknowledging that their remaining lifespan, their other health conditions, and their priorities might be very different. A 50-year-old might prioritize adding years to their life, even if it means undergoing difficult treatments. A 75-year-old might prioritize quality of life and being able to enjoy their grandchildren, even if it means accepting some increased risk. Both approaches are valid, but the healthcare system doesn't always acknowledge this difference. I've been in medicine long enough to see trends change. Tests that were once considered essential are now recognized as harmful. Treatments that were standard of care are now known to do more harm than good. Medical knowledge evolves, but it evolves slowly, and many doctors continue practicing the way they were trained decades ago without staying current on the evidence. That's why I'm sharing this with you. I want you to be informed so you can make the best decisions for yourself. Let me be clear about what I am recommending after 60. Focus on the basics that we know actually improve health and longevity. Stay physically active with both cardiovascular exercise and strength training. Maintain a healthy diet rich in whole foods, vegetables, and lean proteins. Maintain social connections and mental stimulation. Manage chronic conditions like high blood pressure, diabetes, and heart disease with appropriate medications and lifestyle. Get adequate sleep. Avoid smoking and excessive alcohol. These fundamentals have far more impact on your health and longevity than most screening tests. Also, pay attention to symptoms and changes in your body. If something feels wrong, get it checked out. I'm not advocating for ignoring health problems. What I'm advocating against is looking for problems when you feel fine, particularly with tests that have questionable benefit and real harms in older adults. There's a big difference between investigating symptoms and screening asymptomatic people. I want to thank you for watching this far. I know this information might be controversial and might contradict what you've been told by other healthcare providers. My goal isn't to create conflict with your doctor, but to empower you with information so you can have better conversations about your care. Remember, healthcare should be a partnership between you and your physician, not something done to you. You have the right to ask questions, to understand the reasons for recommendations, and to decline tests or treatments that don't align with your values and priorities. If you found this video helpful, please give it a thumbs up and subscribe to the channel. I'm Dr. Michael Thompson, and I'm committed to bringing you evidence-based information about health and fitness that cuts through the noise and gives you practical knowledge you can use. Share this video with anyone you know over 60 who might benefit from this information. And remember, the goal isn't to avoid all medical care, but to make sure the care you receive actually benefits you and aligns with your individual situation and priorities. Take care of yourselves, ask questions, and be your own best health advocate.